A wide variety of syndromes affecting the peripheral nervous system may be encountered in patients with diabetic mellitus. This is probably a reflection of a range of underlying disease mechanisms. Were accepted for the diagnosis of diabetic neuropathy, the already known classification proposed by Dick and Thomas here is a consensus classification due to its simple implementation practice. There are another very interesting and important classification, but I choose this one by the practice classification. First of all, it should be remembered that it's not uncommon for the presentation of neurological syndromes and mix, which may include two or more of the clinical entities that then we will comment. And the diabetes preferentially affects the peripheral nervous system, sensory neurons, and their receptors lie outside the blood-brain barrier and are more vulnerable to injuries secondary to diabetes than motor neurons lie within the barrier. The small amyelinated neurons, the C fibers, or small nerve fibers, are part of the sensory neurons, suffer early damage than the large fibers. And these neurons and the receptors have the nociceptive function of heat and pain. Other special small fibers in conjunction with small C fibers are the thinly myelinated A delta fibers, which are responsible for touch, pressure, and cold. In fully myelinated fibers, A beta and A alpha are responsible for vibratory perception, threshold, and position sense in the space. They are much larger than the small fibers, and myelin from swan cells forms a protective cover to different toxic substances and accelerate the axonal nerve conduction of neurotransmitters. In this image, I try to recreate the characteristic of their sensory functions determined by each of the receptors. They possess an myelinating or its absence. As you can see in the left of the screen, the fully myelinated fibers, and in the right, the thinly myelinated and myelinated fibers. In reality, there are not myelinated fibers. The small C fibers have a very, very light myelinization in these axons. But for the histological pattern, they consider unmyelinated fibers. And there are a correlation between nerve damage and symptoms and surround nerve biopsies with diabetic polyneuropathy presenting symptoms. First patients with new onset pain, burning or pickling, showing early degeneration or loss of C fibers, and subsequently initial demyelination or remyelination of large fibers. Patient present numbness and loss of proprioception from feet and move upward over time. If DPM progress, distal to proximal axonal loss symptoms are the hallmark of the DPM. And you know, when degeneration occurs, axonal atrophy predominantly in the distal nerve and decreased sensory fiber density with demyelination and remyelination. So the therapeutic response will be seriously diminished. Here in the left of your screen, you can see the control biopsy, punch biopsy, and in the other side, you can see the large myelinized neurons with remyelinization, and in the other with the degeneration. Well, the pathophysiology of diabetic neuropathy has focused on the dysregulation in the past 14 years. Hyperglycemia activates important cellular pathways which cause nerve damage. The polyol pathways aldose reductase, ATP depletion, reactive oxide species production. The next one is exosamine pathway that promote inflammatory products, PKC activation, insulin-resistant activation, and the production of advanced glycation end products, AGEs, and their binding receptor, REGES, that promote inflammation, reactive oxide accumulation, and decrease blood nerve flow. And finally is the vascular dysfunction, because the endothelia have a big damage and diabetic complications occur. Here you can see the redox function in the cellular, in the endothelial cellular, and what would be the behavior of endothelial cell in the face of this systemic metabolic alteration? Well, these cells have a limited metabolic capacity to supply glucose. In the cytoplasm, within the electron chain of the mitochondria, is the site where the metabolic process that leads to the balance of the ROS system is established. Given the increase in the glucose substrate, pyruvate dehydrogenase, among the other enzymes, fails to maintain the metabolic rate, with a consequent increase in oxidative stress and reduced endothelial cells. Here we can see the result of this situation in the vascular endothelial cells. The mechanism of cell damage is faced with hyperglycemia, endothelial cells not being able to metabolize this increase in glucose. And what would be the pathological consequence of this increase of glucose? Production of the H precursors. These H precursors modify intracellular proteins that regulate gene transcription. H precursors modify circulating and circulating proteins, producing cytokines and growth factors, and glycosylate messenger proteins, collagen, fibrinogen, are not degraded. And now start adhesion molecules with increased mobility of macrophages and exposure to growth factors of small muscle cells, increasing these small muscle cells, and T lymphocytes with an immune response increase in atherosclerosis plaques, forming complex with oxidized LDL. Here you can see what's the vasoneural injuries. Look at this one, the picture in the control in the left have the very high side of the arterial vessels, and near to this one, the venous. But look at the right, the artery is very thin, and the vein is very rough. And in the other side, the image shows to you the nerves inside of the fascicle, that they have a lot of these kind of vessels that have injuries. This situation provoke a lesion inside of the fascicle. In the lesion is in the vessels and in the neurons. This is the result of the oxidative stress affected nerve receptors, fibers, and vessel structures. Well, at this point, the metabolic syndrome has emerged also as a crucial risk factor for neuropathy. The MS, hyperglycemia, obesity, and dyslipidemia, the metabolic syndrome, and the risk of developing neuropathy increase with the number of these components present in an individual. And one of the very, very interesting and important aspect is pre-diabetes is also an important factor for lesion of a small fiber neuropathy. If we can see in this slide the situation when a lot of studies make the cross-sectional studies of prediabetes and association with diabetic polyneuropathy using a score of symptoms plus physical examination, Michigan score, and consensus of Toronto. You can see the different results of pre-diabetes are presented diabetic polyneuropathy in 11, 13, 49, or 29% versus no diabetic mellitus in 3.5, 7.4, 29, 11.1%. In conclusion, diabetic polyneuropathy is present in a high level in patients who have pre-diabetes. And to remark, this highlights evidence, 7 studies, 5 cross-sectional and 2 longitudinal studies from different countries with a very large number of participants demonstrate the associations between the alcohol and the drink alcohol and diabetes, diabetes and overweight, alcohol and hypertension without diabetes, obesity or diabetes with high BMA, alcohol consumption, HDL, LDL high level, diabetes, and alcohol and triglycerides. These kind of associations promote very quickly lesions in a small and large nerve fiber. But obesity, and independently associated to symmetrical distal neuropathy, it's necessary to thinking a reclassified cause a neuropathy related to obesity. Because without diabetes, patients who have obesity maybe have small nerve fibers lesions. And in metabolic healthy individuals, mitochondria produce in the neuron cell body traffic down the axons, providing energy for normal axon function. And in prediabetes and type 2 diabetes, the chain of injurious events leads to mitochondrial dysfunction with adenosine triphosphatase loss and distal to proximal degeneration of energy-starved actions. Well, I would like to show the summary of the diabetic neuropathy different participants to promote the lesions are here in this screen: obesity, insulin resistance, that joined with dyslipidemia, hyperglycemia, energy overload, bioenergetic failure, the mitochondrial depolarization and loose ATP, inflammation, apoptosis, axonal failure, impaired mitochondrial trafficking, reactive oxytocin spikes in the endoplasmic reticulum stress, have the very important aspects to produce the neuropathy. And dyslipidemia, about the elevation of triglycerides and fatty acids, promotes the inflammation in the mitochondrial in the vessels with mitochondrial dysfunction, and the oxidative damage impair production of use of energy. And what happens if the increase of glucose? This increase of glucose increase reactive oxide species, and this action in the nucleus of the cells to alteration part the chain and produce the activation of the inflammatory pathway. And here you can see the new emerging mechanism to diabetic neuropathy pathogenesis. This is the deoxysphingolipids that promote the apoptosis and play the role to decrease the ATP production in the transport chain, electron transport chain in the mitochondria, and promote the mitochondria dysfunction. Finally, deoxyphingolipids have a toxic action on nerves and pancreatic beta cells because the diabetic metabolic syndrome and less intensity in diabetic type 1 promote the increase of disproportionality of these deoxyphingolipids and action in the ATP production of the mitochondria with a low level of ATP and generate the oxidative stress. This is the final message about the DPN. Non-trial with aldose reductase inhibitor, PKC inhibitor, or RAGE inactivator have been successful. Another one is the control of glucose plays an important role to prevent DPN among type 1 diabetes and DCCT addict, but it's not sufficient to prevent DPN among type 2 diabetes.